like you are too. It's Hi, Fabi.
Hi, good morning, everybody.
Morning. Hi, Joseph. Franklin. I love that we have Ben. Hi, Maristella. Hi, Franklin.
Hi, teacher. Good morning.
We've got the QR code that will work because Joyce did it and I did, not me. And the link to Menti. So we're gonna have just a few slides before we get into the homework. Yeah. Hi, London. I liked some of your questions on in the discussion.
Oh, yeah, thank you.
Yeah. Hi, David. Good people there too. Hi, Johnson. I can hear you. Can you hear me? Oh, not now. Now you're muted. Hi, Nilu.
Good morning. How are you?
Good. Hi, Con.
Good morning, Christy.
Good evening. Thank you for being with us at such a late hour. All right. Well, why don't we get started? I really like this class. It's one of my favorite classes because we get to see really the application of a real world project and how it was designed and the way in which decisions were made. And hopefully you had a chance, I think most of you did, to do the homework, to really think about what you would, what kind of study design you would use, what kind of question you would ask. Before that, I wanted to just spend a few minutes kind of just giving that, reiterating the study design kind of framework, the types of study designs and how we think about it relative to time, with a few questions in Menti. So if you haven't gotten into Menti yet, please do so. And then, so basically we'll do this quick sort of overview with a few questions about study design. We'll spend the majority of the time in the homework that will be led by Dr. Sarah Kinter, who's with us today. And I'll let her introduce herself when we start the homework. And then if we have time at the end, I've seen many of you post questions and I think it would be really nice to have a discussion around those. If we don't have time, then I'll pop in and I'll answer the questions that have come through primarily over the weekend. So let's see here. Okay, well, why don't we get started then? And if you're having any trouble getting in, please let, oh, I'm disabled, Joyce. Can you able me? Share. All right, now I'm good. Okay. Okay. So, great. Okay. So this is our quick agenda that I went over. I wanted to just jump into observational study design recap to make sure we know kind of the really big fundamentals about how we think about these various study designs. So just to start with, why don't you all rank order these study designs by rigor? So I think you should be able to go in and say, what is your first choice? The strongest to the weakest in terms of the rigor.
Last year. No, last month. Last month. How did it happen?
Are you guys able to get in? Hi, Linus. There we go. Excellent. Got 3. I'll wait a few more minutes and make sure you guys are in and you've got a chance to respond. Yeah, this is great. All right. Yep. Coming in. Okay. Yeah, this is right. So of these study designs, our most rigorous is typically our retrospective cohort. That you can have rigor in any of these study designs. But I think in terms of often what we find is that the rigor is going to be the highest in our cohort studies, followed by our case control studies, cross-sectional, and case series. And that follows the pyramid that you typically will see. Okay, so then here's the next question. So this study design, and you're going to pick, you can pick more than one of these. First selects participants on the basis of having or not having an exposure and follows individuals over time. Four, right? 6, excellent. Mhm. All right, looks like we've got 10. Yeah, okay, so we've got a few people who selected more than one, which is great. Yes, prospective cohort studies classify individuals on the basis of having an exposure and then looking over time to see an outcome. But retrospective cohorts actually do the same thing. It's just that everything has already happened. But when we start our retrospective cohort studies, we classify people on the basis of whether or not they had some exposure, say they had a cleft lip versus a cleft lip and palate. And then we follow them over time to see what their outcome could be, a growth pattern. And all of this data already exists in a medical record. And we know that growth happened of the child happened after the exposure, which would be having an orofacial cleft. And so in this case, we have this paradigm where our exposure, we're classifying people and then we're following them over time, is still true. We know that growth happened after the cleft, but it all exists, all the data exists already. So that's sort of the fundamental foundation for a case, a cohort study. So are there any questions about that before we move on? I can't see the chat, so if there are chats, please let me know.
Nothing in chat, Christy.
All right. And so this is essentially a different kind of example where you could have this prospectively, where you're enrolling individuals according to when they had surgery and then following them their weight over time. This also could have happened and be in the electronic record. And so you could do this as a prospective cohort study or a retrospective cohort study. And you'll remember that the advantage of a prospective cohort study is we get to figure out what we want to collect. We're not relying just on the data that exist. But a retrospective study, we can often do with a larger number of individuals, or if the data already exist, it can be a lot less costly. Our prospective cohort studies tend to be a lot more expensive. All right. So this study will first select participants with and without the outcome. We've got a few more people to, and then, okay, we have a, yep. Yeah, I think the majority of you are on point. When we design a case control study, we start with the outcome. We start by choosing individuals who have our outcome of interest. And then we look back to see what they were exposed to. And yeah, looks like there's one new message. Yeah, case control. That's right, Mubarak.
Mteja uliyempigia amekusubirisha. Tafadhali subiri.
So yeah, so I think there's case series. So the issue with the case series is that we don't have a comparison. So we don't have people in a case series that don't have the outcome of interest. Whereas with a retrospective cohort, reflecting on the last slide, we're choosing people not on whether or not they had the outcome, but whether they had the exposure. That's how we're grouping our participants. And then our cross-sectional study, we actually choose people at the same time. So I have a quick slide about this. So in this case, we're looking at, we're starting by choosing individuals that have an orofacial cleft or not. And we're looking back in time to see if their mother had high levels or low levels of folic acid. Maybe that's through a supplement, maybe it, is a self-report. It just depends on how you can get that data. But we're first choosing to select people into our study on the basis of whether or not they had the outcome of interest. The reason we do this is when we have less common conditions, when our disease is rare, this can be much more efficient study design. So the example I like to give, and I think for many of you who see patients with cleft on a regular basis, it seems like there are a lot of children with orofacial clefts. But the reality is it's about 1 in 500 to 1 in 1,000 live births. So it's not really that many individuals at a population level. So if you wanted to do a prospective cohort study of 100 kids that were born with a cleft, you would need to then screen or to do a prospective study, 70,000 people to get 100 cases of cleft. So you're talking about it's very inefficient unless you're at a center where you have high volumes. So we often
Mteja uliyempigia amekusubirisha. Tafadhali subiri.
Joseph, can you, yeah, there we go. I muted you. So anyway, this is basically we're choosing people on the basis of an outcome. And then of course, our cross-sectional studies, we get people at the same point in time. So an example of this is you're capturing in clinic individuals that have periodontal disease and you're assessing their quality of life. And you're capturing them at clinic at a particular point in time. And you're then putting them into these 4 groupings. And so you don't actually know what came first, if the periodontal disease came first, or if there was a poor quality of life and people stopped brushing or doing behaviors that enhanced periodontal disease. So in this case, we take this group of people and then we just put them into these 4 bins. So this is much more, it's a lower level of evidence, primarily because we often don't know what came first. We don't have temporality like we do with our cohort studies. So I just have one more slide that I wanted to kind of make sure that you have at your fingertips. It's really confusing, I think, for people when they're first learning this to think about what the time order is for our study designs. So in our randomized clinical trials and any cohort study, you have an exposure that or an intervention precedes your outcome or your disease. For our, that's prospective. For our cohort or retrospective, we have the same pattern. It's just that all the data have already happened at the time that we start our study. So it's the same exposure disease pathway. We identify people that have the exposure and then follow them up for disease. It's just a matter of when we start our study and what data are currently available at the time that we start. With our case control studies, we're going back in time. So we're selecting people on the basis of the disease and then looking back to see what exposures they have. And with our cross-sectional studies, we're capturing those two things at the same point in time. So I just wanted to kind of pause there and see if there are any questions about this. And we can definitely talk more after the homework about questions that you all had. I think I'll just touch on one question really quickly, which is, what's the difference between a cohort study and a case series? There, can you do prospective case series or retrospective case series? And I would say the primary difference is that with a cohort study, you have a comparison group. In case series, we only have a group of individuals that have the outcome. We don't have a group of people that don't have the exposure of interest. So the power of, it's why case series tend to be at the lowest level of evidence, is we don't have a comparison group. And that really hampers our ability to ask questions and to make inference from a case series. Okay, any questions? Oh, and I just point out there's lots of different study approaches. This is not the end of study design. These are the core study designs that we use in epidemiology. There are study designs that study pre and post, so following the exact same people without a comparison group, before and after something that you do in the clinic or a new effort to improve feeding, whatever it may be. You don't have a comparison group though, so you're more limited in that. And we have quality improvement studies, and we actually have an optional module on that, and I'm going to post that so that if you're interested in quality improvement, you can look at that. Quality improvement is not considered research, and so it's meant to improve the processes at your hospital, and it doesn't tend to lend itself to being generalizable to other settings. So it's a very important tool if you're trying to improve care in your hospital, but it's not considered research, which is absolutely fine. It is rigorous and it does have a scientific method. It's just that the primary difference is that it's not necessarily relevant to other, what you do at your hospital is very specific to your hospital. There's been a really big move towards data science, and one of the big sort of new tools that people are really, or sort of approaches, is trying to predict outcomes. And predictive models typically requires a tremendous amount of data. It's a different kind of study approach. It doesn't use the sort of traditional epidemiologic study designs that we've talked about. And measurement studies, this is where we might want to develop a new tool, and we have a guest speaker who's going to talk more about this, as well as qualitative research, which is rich in information, but it's not quantitative. And what we've really focused on here is quantitative. We do have a session later in the program with a qualitative researcher, so you can learn a little bit more about how that study design works. So any questions about study design, I think more broadly?
No, thank you.
Okay, you sure? I think once you start applying it, you end up having lots of questions for your particular studies. All right, I'm going to stop my share. And I'll just say a couple of words about Sarah, and then I'll let her continue to introduce herself with the homework. Sarah is a wonderful colleague, also based at Seattle Children's, and she has a PhD in epidemiology as well as an experienced speech language pathologist. been in the Community Officials Center for, I don't know, probably 15 years, maybe more.
It'll be 20 years next year.
Yeah, 20 years. So I think this is, Sarah's in this very unique position where she has a wealth of clinical experience and then has a PhD in epidemiology, and really trying to address problems that affect speech in children. So it was her dissertation that this study was based on. So I think it'll be an interesting discussion. And Sarah, I'll let you take it away.
Okay. Thank you everybody for being here. It is very early in the morning here. I know you're all in different time zones. So this Christy mentioned this was done as part of it was my dissertation. And I was very lucky to have access to, a set of patients where I worked as part of my program. And so this is just kind of the decisions that I went through, over the 2 years probably it took to actually get the study done. So what I'm going to do is just go through and I'll read what the questions are and then just open it up for discussion before I just tell you what actually happened in reality. Yes.
I'll add that we really encourage you to type in the chat, to respond to the questions, that this is like sort of the reality of you consider lots of different options as you think through. And so, and there's different ways to skin the cat. This was one way that was chosen, and there are really good reasons for it. But I think just thinking broadly, like what would you consider and what would your answers be? And they don't have to be right. It's part of the discussion, part of the learning.
Yeah. And I think something to keep in mind too is what worked in my setting won't work in all settings. And so those are other things to consider too. Just to start, what was kind of the general question of interest that I was looking at? Is it clear that there was like a specific association that I was interested in measuring?
Eric,
is that a yes? Okay.
Nilu has
it. I'm seeing like things flash on the screen. Here, let me pull up the chat.
Development of VPI after advancement.
Yes. Yeah. Absolutely. And was there well, I guess that will get into a later question. Did anyone have any different impressions of what kind of the general question was? What do we think about before we move on to the next question, like what part of the summary kind of led you to this answer? Because it is true that it was VPI after maxillary advancement. What part of the summary there kind of led you to that conclusion?
All right, I'm going to put the problem summary in the chat so you guys can kind of look it over and remind yourself if you did the homework earlier. And why don't we just kind of stop for a second and give people a minute or two to look at this over? Does that sound good, Sarah? Just to kind of remind.
Sure. Yeah. Yep.
Yeah, so we've got another answer in the chat. That's great. Thank you, Marcella. What is the best procedure, DO or TMA, to avoid VPI?
Yep.
Patients would be best. Yep, Johanna, I love it. Would be best treated by DO versus TMI. Yep, Franklin, to evaluate the aesthetic results after primary rhinoplasty and lip surgery. Sarah, can you see the?
Yeah, I'm looking at it. Yeah, so I think the which procedure is, I like this because it's getting a little bit more detailed in the question, which makes it easier to investigate and test relationships. And so what's the best procedure to avoid VPI? And then here, which patients would best be treated by distraction versus conventional advancement? I think in relation to that one, the group under study, it was a relatively heterogeneous group that I was looking at. And so I was able to do some degree of looking at the different subgroups that might be differentially impacted. But the initial question was, is distraction related to lower risk of VPI after surgery? And Franklin, the aesthetic results after rhinoplasty and lip that sounds like a great study. And so this was looking at my dissertation was particularly looking at a group of patients who had cleft palate with or without cleft lip. They were all undergoing maxillary advancement surgery, but there are two types of surgery. One of them is distraction, which is done over time. And the other one, they call it conventional advancement or traditional maxillary advancement, TMA here. And some people, surgeons, providers, felt like distraction lowered the risk of VPI, but there just was not a lot of evidence. And so ultimately, well, I won't give that away, but it was clear, back to the subgroup piece, that was clear at the end of the study. I was able to look back at things, but that wasn't the primary question when I started.
But Franklin, sounds like a great prospective cohort study.
It does.
I'm going to type the next question in.
Yep. Here we go. So what is the researchable statistically testable hypothesis? I sort of just alluded to this a little bit.
So I think we talked about having two types of surgery, right?
Mm-hmm.
And which do we think, like, yep, yeah, great.
Yep.
Yeah.
So we have here patients who have maxillary advancement have a greater risk of developing VPI. Either TMA or DO would highly likely result in development of VPI among patients with or without cleft lip and palate. And so, yes, any other responses before I
Do you
jump
think
in?
the actionality, like based on the, if you scroll up and look at the problem statement, which intervention do you think would result in better outcomes? Do you have a sense of that? Or if you have clinical knowledge, what do you think? Which of these would, yeah. The null hypothesis, yeah. And Nilu, there's no difference in the development of VPI after DO compared to TMA. And Maristella, that's true. Both of those are right. If you had to say the alternative, and this is what we usually do like in grant proposals, because that directionality sort of stakes a claim and is more specific than the null. What do you think? Do you think DO, which one do you think would be, what difference would there be, and what direction would there be a difference? And I'll tell you, this would be a question that I would ask somebody if I was consulting, because I don't know I don't have any idea about the clinical component. But I think this is where I would push people to say, you need a direction. You want to make sure you have a very clear expectation, because those hypotheses end up being, it gives you a lot more clarity when you get the answer. Yeah. Maybe we don't have any other speech language pathologists that have that know either.
No SLPs in the room? Okay, just me. So, I think in reviewing the literature, and this is what I did initially, and I also was drawing on my clinical experience as someone who, we do speech evaluations before and after this particular type of surgery. And there was a lot of talk about, if we do distraction, that would reduce the risk of VPI because there is more time involved in the movement than there is with conventional advancement. And so the thought has been that with more time, the muscles have more time to acclimate to change, and that would result in lower prevalence of VPI after surgery than conventional advancement, which happens in a single surgery. The patient undergoes surgery, they move the upper jaw forward, and then they stabilize it in place, and then it's done. Whereas distraction, the patient undergoes surgery, they mobilize the maxilla, and then they put distractors on, and then the patient comes out of surgery, but the movement occurs over a period of weeks. And then they have another procedure to remove the hardware. Yes.
Sure. And I would say the thing I really liked about Sarah's answer is there's very good clinical rationale and scientific rationale for coming up with a hypothesis. Is she right? Well, that's why she's asking the question, because you don't know, right? You think you know, but it may be different. But there's a good reason, and I think she did a nice job of explaining scientifically why this is the direction that she proposed would be the case. All right.
Yep.
I'll pop in the next one, Sarah.
Okay. Yep. All right. So the PICO framework. So let's start with, this has come up a little bit in the chat already, but let's focus a little bit on thinking about exactly what kind of patients or study population I was looking at. I think somebody mentioned patients with or without cleft lip and palate. Does it look like there were patients that did not have cleft palate in the cohort? Because I think if we have patients that don't have cleft palate, then we have a slightly different question, because they're a very different group than patients who have cleft palate. And the question wasn't whether or not the risk of VPI was greater with those with and without cleft. The question was whether or not the risk of VPI was less in distraction versus traditional advancement. And so other thoughts here on, yes, so we have children with cleft palate with or without cleft lip, absolutely. And yes, also patients with cleft lip and palate and maxillary hypoplasia requiring advancement. Oh, this is all of it. Okay. Yes. Great. Okay. And then exposure, and then the comparison group. It looks like people have that down. Yes. So somebody here mentions the time. Yes, time is pre and post surgery. Before I get to that, let me do yes, I think I was comparing distraction versus conventional advancement. And so because my question was does distraction lower risk of VPI, then that would be the exposure. And then the comparison is those who underwent conventional advancement. And then I know I'm seeing comments about timing. I want to get, what was the outcome I was looking at? Was I looking at, yep. So Lydia says VPI.
Yep.
Yes, VPI, yes. Yes, so the outcome here was VPI. I think just a note here. There are VPI and speech intelligibility. Yes, well, the reason I didn't formally assess intelligibility was because I didn't have all the data needed to do that in a rigorous way with the data that I had available. And so that's what Christy was just mentioning. With retrospective cohort studies, you have the data that you have and you can't create more data. Otherwise you're doing a different study. And so yes, speech intelligibility is a valid outcome, but for the data I had, I didn't have that information. So I was just using ratings of VPI severity that was present in the medical record. Okay. And then for the time point, someone here mentioned that the time point was unclear. And so, and also there was comment about pre and post. So in order to get the outcome, I needed to know what was present before surgery. And so yes, there is pre-post measurement because we need to know that if there is VPI after surgery, that it was as a result of the surgery and wasn't present before the surgery. And so anyone in the analysis, anyone who had VPI before surgery was actually excluded from the analysis because otherwise we wouldn't be able to, it's not part of the, they're not eligible for the outcome if they have it before the surgery happened.
I wanted to add one quick thing because I had just
Yeah.
mentioned post studies.
Mm-hmm.
And you know, the difference in this case is you have a comparison. So in cohort studies, we often will measure pre sort of baseline and then follow groups over time. And so we have pre and post measures, but we have pre and post measures for both two groups, those that have our exposure of interest, in this case,
Yeah.
say TO, and those that are our comparison group, so maxillary advancement. So so the case that's sort of different than a pre-post because we have a comparison group.
Right. Yeah. Yeah, absolutely. And so the outcome then related to the timing was the outcome was measured roughly 3 months after maxillary advancement surgery or DO. And that time point was chosen because it's just part of our clinical protocol at my institution that is when we measure speech after this particular surgery. If we measured it immediately after surgery, we wouldn't have given the patients enough time to acclimate to the anatomic changes. And so it may not have been the final outcome, like what would impact them in day-to-day life, you know, a year from then. But this is also a cohort, they're late adolescents, early adults, and if there is a negative speech change, we don't want to just leave it there for a while until we can get, you know, a later measurement. we wanted to manage it if there was going to be something present. And so the literature is not fantastic with exactly when we should be measuring this, but there is some support that says that the speech outcome at around 3 months of age tends to not change following that time. So that was how we chose that. And that's also when we assess it clinically. And so that was the data that was available to me as well. Okay. Primary outcome of interest. We talked about this already. So yes, we have the presence of VPI and 3 months postoperatively, but let's talk a little bit about how I landed on that as the outcome.
I
Is-
want to point one thing out just about
Yeah.
a few things Sarah mentioned, which is measuring VPI at 3 months because it coordinated with the clinical protocol. And if I think, if that's as long as if you can measure outcome at a time that fits into routine clinical protocols, you're going to have much better follow-up. You're going to have more people that are in your study than if you had them come in at 4.5 months, because it's an extra trip. You might not be able to measure it. It may not be in the record. So, when we're thinking about, you want to make sure that there's enough time for your outcome to have occurred.
Yeah.
Measure it a week after, that's probably not enough time, right? So clinically, Sarah and colleagues determined that 3 months was reasonable and then also fit within existing protocol and frameworks. So we always look pretty carefully at key time points when care is delivered, when we're designing studies to see, is that an appropriate time? Is there enough time for the outcome to develop, and make that part of our consideration? I have just one question. Do you think VPI, is that a true or a surrogate outcome? What do people think? Does VPI matter to patients? We have
Lydia
one.
says true outcome.
What do other people think? Mhm.
Yep, so we have Eric suggests surrogate outcome because the expected or ideal outcome is correction of mid-face hypoplasia. Others say, oh, a lot of back and forth on true versus surrogate here. That's interesting. True. Yeah. A VPI, and then there's comment about it's a surrogate because speech intelligibility is the true outcome. This brings up a lot of interesting questions, especially related to speech in the grant I'm currently writing right now. So I would consider it a true outcome. But the comments here are actually bringing up a lot of great subtleties, especially when you're talking about speech in general as an outcome. And so Eric mentions the ideal outcome is correction of mid-face hypoplasia. One of the challenges with this particular surgery is there are a lot of different outcomes to consider, and what you do to maximize the benefit or the positive outcome, they kind of all compete with each other. And so outcomes of maxillary advancement surgery as a whole are, the aesthetic change, the speech change. There's other parts of speech that improve, but VPI is an adverse outcome. There's also, it can increase the patency of the nasal airway. It improves the occlusion, and so chewing might improve. But I wasn't assessing all of these outcomes. I was just focusing in on the speech. And so on VPI specifically. And so I wasn't drawing any conclusions based on other outcomes. I was only looking at VPI in particular. The comment here about speech intelligibility, well, the other challenge with assessing speech in general as an outcome is there's a lot of components to it. And so speech intelligibility also, as a speech pathologist, we think about that. You can have differences in your speech if you just think about people you know, that are not necessarily, don't impact your ability to understand them. You just notice that they sound a little bit different than you would expect. So which one is most valid? And that just depends on who you ask. And so again, to be really clear on what I was measuring, as well as the data that I had to analyze, I was just focusing on VPI. I wanted to look, there was something else. Speech and outcome, yes. VPI, a true outcome because it directly affects speech and quality of life. Yes, so I would agree that it is a true outcome. Some other surrogate outcome, other ways to measure outcome that would still be sort of a proxy of VPI would be if you only looked at surgical codes that said that that patient had surgery for VPI at some point, would be one way to do it. And certainly people have done that because that's data that's available in like large databases, sometimes like nationally available databases. The reason I, the reason I didn't do that was because not every patient who presents with new VPI after maxillary advancement opts to have surgery. And so if I only measured those that had surgery, I would be measuring those that had more severe VPI, likely, and I wouldn't be measuring the true burden of VPI in the population because I would be missing those that had VPI who might not consider that a fantastic outcome, but it wasn't problematic enough for them to want to have yet another surgical procedure. And so that was why I did not do surgery as the outcome. There's also a lot of different ways to measure VPI. And so sometimes people will do a nasendoscopy where they do the scope in the nose and you can actually watch the muscles move during speech. And they will diagnose VPI if there is a gap there when there shouldn't be. There's several reasons I didn't do that. Number one is if a patient doesn't have VPI after surgery, we wouldn't scope them. And we don't want to, do another procedure like that if we don't need to. And so clinically, that information wouldn't have been available for any patients who didn't have VPI after this particular surgery, looking at a retrospective data set. And number two, just because there is a little bit of a gap doesn't necessarily correlate with whether or not we perceive VPI in the person's speech. And so it's not quite a direct measurement. And the gold standard for VPI diagnosis clinically is perceptual evaluation of VPI. Unless there are other comments related to now the primary outcome, we're going to go on to the next question. And let's talk about the study design and what study design was feasible, given the information that I had. And that would produce the highest level of evidence, kind of striking that balance.
What do you guys think? Randomized controlled trial, that would be awesome.
I would love to do that. So randomized controlled trials, yes, they are the highest level of evidence. And so there you've got like a check in the let's do that box. Yep. Yep. Other people are commenting on cohort. The challenge with a controlled trial in this context were several. Number one, they're incredibly expensive. And I didn't have that kind of money as a doctoral student. Number two, they take a lot of time. So this is all prospective data collection, and they take a lot of time to collect all that information. And this would be true for a prospective cohort study too. And so in order to have enough patients to have adequate power to analyze, it would take me like 3+ years to get that amount of patients. And it just wasn't feasible if I wanted to graduate in a timely manner. And number three, and I think most importantly, there really isn't agreement with surgeons that are doing this procedure, and there wouldn't be buy-in from the surgeons that actually do these procedures to randomize patients to one approach or the other. And so it just wouldn't happen at my institution, at least. And yes, it is a rare and specific condition. And so yes, cohort study is better. I will say that and another reason I didn't do prospective cohort is also because of the time involved. That was actually discussed quite a bit because I wanted to do prospective, but it just wasn't feasible. The other piece to keep in mind that impacted all of us was this was also done during the COVID pandemic, and so there wasn't a lot of surgeries happening at that particular point in time, nor could we evaluate VPI. And so I was using data that was already available. And I think, does anyone have any other comments about like if they have different thoughts on decisions that they would have made that were different than what I did? Would you have preferred to stick out the time and wait to have all that just to have the prospective design? We have a questioner. How do you control confounding factors like the amount of advancement? That's a great question. So yes, that was controlled for in the analysis. So part of the clinical protocol is that patients before the surgery undergo lateral cephs. So they're just x-rays looking at the side. And so we had all of that information already. And so I was able to pull those, and I designed my own analysis for different things that I wanted to look at. But we were able to measure amount of maxillary advancement. And so all of the analyses were controlled for amount of advancement. And that's also really important because it's also true that some surgeons prefer distraction in patients who have more advancement. And so if I didn't control for that, then I was potentially looking at, I was going to be mixing, and maybe the results were because of the amount of advancement and not actually the surgery, the surgical approach, I should say. And so because I had that information, I was able to control for confounding. And I would argue that if I didn't have access to that, I wouldn't have been able to do the study. If that confounding variable was missing, it would be really hard to draw inference from any results, because that's a big confounder. I also controlled for type of cleft as well, because there are potentially some differences there. And there's also differences in how our surgeons repair the cleft when they're babies, based on the type of cleft. And so there's potentially anatomic or physiologic differences in type of cleft that could be impacting whether or not they were at greater risk of developing BPI.
I want to just comment a little bit, I think it's so tempting to propose RCTs because they're our highest level of evidence. And yet it's one of the most challenging studies to conduct if we're talking about surgeries, because there's often really strong opinions about what surgery is and what approach is best. So even like, and Sarah, I think you're site PI for Cornet, right? Like we have this very large network looking at surgical treatments and speech outcomes, and it's not an RCT. And it's millions and millions of dollars that have been spent by our federal government to study this. And the reason it's not an RCT is it's not feasible. People are not willing to randomize to certain surgeries. And that's okay. It's what it means is that the highest level of feasible evidence that we're able to generate is a rigorous prospective cohort study with multiple multiple sites. If you're doing your PhD, you want to graduate, quite frankly, right? It's not supposed to be your best research. It's supposed to be your best research. You're supposed to be learning how to do this work. And you want to put together something that's rigorous, that moves the field forward because you're addressing gap in knowledge, but that will also fulfill the other goals that you have. So there's this sort of art and science, there's the science part of it, right? The theory and like the application, and this is what we do. And then there's the sort of reality, and it's like, what's feasible and what's science, what's feasible and what's a good question. So we're often like having to kind of, like Sarah said, we spend a lot of time talking about whether we should do a prospective study versus a retrospective study. And at the end of the day, it comes down to sort of navigating the balance between, feasibility and goals and timelines. If you have the US government giving you millions of dollars, you can do prospective studies with lots of sites that require 5-10 years of follow-up. But if you don't have that, what can you do that will move the field forward? What questions are important, and what data is it feasible for you to actually collect to answer a question that can add new knowledge and help people make better decisions for their patients? So I don't know, Sarah, if you want to talk a little bit about Cornet. I don't know that much about it, but I think it's just a nice example of, we're not doing an RCT.
Yes, before I get to that though, Eric has a question here. Did I do an equal number of those that had distraction versus conventional advancement? The answer to that is no. I used the data I had. And so if I had limited it to have an equal amount, I would have had a significantly smaller study population. And so in reality, I had the ratio of distraction to conventional advancement was about 1 to 3. And that's held pretty consistent with newer data I've looked at, after this was done. And so when the numbers are discrepant like that between the two exposure groups, it does impact like precision in the analysis, and it's not ideal, but it was better than saying, okay, I have to exclude, 2/3 of the cohort so that I have equal numbers. And I just needed to acknowledge that when I was discussing, limitations and things like that. Cornet. Cornet is a study that is looking at hang on. Yeah, before I move on from this, Christy, I just want to
Maristella.
yes. Go ahead.
Yeah, do you want to answer, Sarah, or I can? Either way.
Yeah. So we probably both have a response to this based on our experience. So in an ideal world, yes, we would start with, the very basic, I can't think about what would be like basic science related to VPI specifically, but yes, you would start with really basic science. You might then, do something like a case series of patients, and that actually has been done a lot, and that's part of the challenge now, is that people haven't advanced the level of evidence beyond a lot of case series. And so for this particular study, I was kind of meeting the field where it was at and then just pushing it a little bit further. That was my goal. And my dissertation chair kept saying to me, like, this is not like your seminal work, like this is just the beginning. And so I think we have to remember that in research, you have to start somewhere. And if you're always looking at the very best and the RCT and only doing that, then you're going to miss out on an opportunity to contribute a lot to your field. And I think what we get reminded a lot in the US is, I think it was the risk of lung cancer in patients who smoke. That was actually identified with a whole series of retrospective cohort studies, and not RCTs, because you couldn't test that, right? You couldn't like make people not smoke and then make people smoke and then test that. And so it's just retrospective. I think it is highly valuable, but it is true that like my dissertation by itself should not make people make massive changes to their clinical practice, but it should inform the things that they consider as they're talking with families. And then the studies need to be replicated and done in slightly different ways to kind of get a body of evidence that then leads you to make changes in practice. So the Cornet, go ahead, Christy.
Oh, I was just gonna say, like, I want to make sure we have a bit of time to get to some of the questions that people had. So I
Yeah.
actually posted the link to Cornet.
Okay.
So this is an NIH reporter, and it's a great place to look if you're looking to see what other people are doing. NIH Reporter is a tool where all federally funded studies exist. So you can read about the abstract, the public health relevance. You can learn who the investigators are. So I would just suggest, if you want to learn more, that's a good place to go. And then I think maybe we'll just skip to questions, because I don't want us to, I just want to make sure we have some time. There's some really good questions that I wanted to answer for people. And if you have questions about the Cornet or Sarah study, you can post them in the discussion after class that you have, and where we can answer those. Maristella, to your point about do you start with lab, do you start with animals and then gradually work up? It's a very traditional way of thinking about the sequence. And in some cases, absolutely, we have to have the fundamental knowledge, say, to develop a vaccine. And that's going to start in a lab. It may start in mouse models, right? But it can happen at any level. So like, observations in clinical and in populations can then inform basic science. So I'll take the example of sudden infant death syndrome. We started noticing that the babies who are more likely to die from SIDS, or sudden infant death syndrome, are placed on their stomachs back. That was an observation on like autopsy. And we're still actually spending a lot of time trying to figure out in the lab, what is the mechanism? We don't know, but we know if we place our babies on their backs, that they're less likely to die of SIDS. And so I think discovery can happen at any place in the translational spectrum. They can start in the lab and it can start in the clinic. And it doesn't always, there is this sort of linear expectation, but it doesn't always follow that. So I think it's sort of informing both ends simultaneously is often what happens. People go back to the bench based on what they've learned in populations, and vice versa. Okay, so I'm just going to post a few of the questions that were in the discussion in the chat here. So one of the questions was, what's the difference basically between a pilot study and a case series? And I would say that so case series, we don't have a comparison group. We have a group of people with the condition that we're interested in. In pilot studies, we're really focused on trying to answer a couple of questions that will launch us into a bigger study, right? So we want to know, is what we're doing feasible? Is it possible to get people back to do an assessment 6 months after they had surgery? Is it possible to actually, get a sample to the lab in the time frame that's required in order to get the test done that will give us the answer that we need from that blood sample or whatever kind of sample it is? So based on your question, there's always sort of these like, is this going to be a problem? And so pilot studies where we have a group with and without our intervention, our exposure, we typically do them when we're doing prospective studies. That will actually give you a lot of information about how to proceed. And then the other thing is a lot of times we use pilot studies to estimate effect size and the amount of variability so we can do our power calculations. So their purposes are really different. We typically have both groups that we want to study in a larger study in a pilot. And our pilot is small. It can be, 5 to 30 people, or, it just depends on, and you're not powering your pilot to answer the question. Pilot studies do not need power calculations because that's not the goal. The goal is to understand what the effect size is, to get more information to do something bigger. If there are any questions about what I'm throwing out, please feel free to put them in the chat or just chime in. Okay. All right, this next question is about matching in case control studies. So you can control, so basically the reason we match, the reason in a case control study is confounding. And confounding at its simplest form is the issue of having some third variable, not your exposure, not your outcome, but some third variable that influences this relationship that you're trying to estimate. And so we have a lot of different ways that we address confounding. And one of them is matching. We will get people who are in the same age group or the same sex. And so the question here is, you can control, you're right, you can control for confounding in a statistical analysis. You can also control for confounding when you match. So you have equal numbers in a case control study on sex, for example. So you have equal numbers of boys and girls and you're recruiting people. So you have in your cases and your controls, it's 50% girls and 50% boys. Great. So the question is like, can you recruit as many controls as possible and then use the statistics to control for confounding? So what's probably the best strategy is to only choose matching variables that are really impactful, where you don't have, matching is actually pretty complicated in practice to find, especially if you start matching on more than 1 or 2 factors. Getting people that have all of those criteria, it's really difficult. So sex is it's a terrible variable to match on, because in our population, about 50% are women and about 50% are men. And so if you recruit just without consideration, you might have some imbalances, but that's something that's really easy to control for in a statistical analysis. It may be very hard to control for some other factor that's really important to your outcome. I'm trying to think of an example. Maybe there's like, you think socioeconomic status is really important, but where you live, it's all really wealthy people, and there's not very many poor people. You may want to have, and you want to have equal numbers in your cases and controls. You would match on that. So matching ends up being, you can use different strategies. I think the take-home message is you can use different strategies, and it's really good to have discussions about what, if anything, to match on. I don't match very much in the case control studies that I've done. I think we've matched once, and it was really hard. And it was basically on site so that we had the same number of cases and controls from each hospital because the patient populations from each hospital might be different. So, if it's common, then you don't need to match on it, don't match on it. But it's a more complicated conversation. And if you had a use case, I'm more than happy to talk with you about it in like office hours. Okay. Let's see here. Can I use this concept to match to a cohort study? We don't usually match on cohort studies. I mean, you'd have to have a good reason. Sarah, I don't.
Yeah, I agree. I think the biggest challenge, well, I don't match very often either. And the biggest challenge with matching is that it really impacts the type of statistical analysis you can do. And that analysis may or may not tell you what you are wanting to know. And as Christy said, there's often not a great match for everybody in the cohort. And so do you just drop them and not analyze them? You know, that may not be a big deal if you've got 1,000 patients, but it might be a big deal if you've got 30. So and matching is just another way to control for confounding. It's not the only way. So it's just another thing that we have to consider pros and cons of.
Yeah, I think that the lean is toward controlling for confounding in your statistical analysis. The other thing is match on it, you cannot analyze that factor. If you match on sex, you cannot look at sex as a predictor of your outcome. So matching can get kind of tricky. So yeah, okay. The next question is, how does including an unequal number of cases and controls affect the power of a case control study? This is a great question because this is exactly what it does. So a lot of times, you know, when we do case control studies, we're studying rare conditions, right? And it makes it, sometimes it's really hard to get enough cases because the condition's not that common. And so one way that we can increase the power of our study is to choose more controls. So we can have, you know, it's very common to have 2 to 4 controls per case. And by having that, you actually increase the power to detect associations. And so the number of controls per case we select will increase the power. So when we're doing case control studies, we often have to collect data. We have to go talk to the parent or the patient and ask them questions about their prior exposures. And so that does become a bit of a cost issue. And so a lot of times you get the biggest bang for your buck by including like 2 to 3 controls per case. You can get more if you're doing like you have electronic records and you've got 100 cases, but there's 5,000 controls that you can choose from because it's all electronic health records. It already exists. You can have more, but the gain in power really sort of levels around 4 controls per case. Beyond that, you don't get a lot of bang for your buck, if you will. So we choose multiple controls per case to increase power to detect associations. Yeah. There's a question about if a case series is the same as a case report. And the primary difference, which I think somebody else alluded to, is just that case reports typically like 1 person. Sometimes a case report, people will include 2 people. Case series can be quite large, actually. It's just that you have no comparison group and you have only a group of individuals with your case series. Often case series are not that big, 100, 30. I've seen, but you can have a case series with like 1,000 people in it if you wanted to. But mostly they tend to be, it's just a matter of numbers. And there are actually different reporting. And if you go to the Equator Network, and if you just type in Equator Network, you'll find those criteria. the Equator Network has guidelines for how you would report a case series and a case report. So you're going to provide, basically a case report is you have this one case that you don't think anybody has ever seen or reported on before. It's highly unusual and incredibly unique. And you think that just by talking about this one patient, we might be able to learn about a new condition or a new aspect of a condition that nobody's ever talked about. It's like very, and case series are similar, but they tend to kind of, you're doing it because people kind of hang together in some way. And you can learn something new. Both of those designs are incredibly limited because you have no control group. So they're not that informative at the end of the day. Can I do a biostat to analyze a case series, or is it just descriptive? So if you have, it depends on the numbers that you have. It's hard to do statistical analysis on 20 people. You can, but you're not, you can describe your sample. That's absolutely, it's great to do that. It's helpful, but you need a comparison group. So if you get to a really large, say I'm studying a case series of children with orofacial cleft, I have 1,000 kids in my sample. Well, now I could start to think like, oh, I could compare children with cleft lip to those with cleft palate. And now you're thinking, okay, well, now I have a comparison group. Is it a case series anymore? It may not be, and you want to think about what other kinds of study design you're actually using, because now you have a comparison group. So you can use the same set of data in different study designs, especially when it's existing. Yeah. There was somebody who they saw this section in the reading about a crossover study. So what is a crossover study? And can we have an example of one? I actually did one. I did it in Ghana. And it was a randomized clinical trial that was a crossover study. And we were looking at 2 types of devices to feed babies with an orofacial cleft. And we wanted to really understand the function of, so these were infants that had difficulty feeding, and World Health Organization in low resource settings recommends that bottles are not used because of water safety issues and contamination, and that cups should be used. And so there was a standard cup that was being used in Ghana, and we had designed something called the Nifty cup, which was a new shape that had a sort of a novel lip to it. And we wanted to, like, in the same time frame, how much milk is getting in. And what are patients' experiences like? Do the mothers like it? What would they change about it? So we actually randomized, we wanted to understand the experience with cup feeding, and we randomized them to either, the standard cup or the Nifty cup. But we wanted to make sure that everybody had a chance to use both. So then after they had used the standard cup for 3 feeds, they crossed over and they used the Nifty cup. And they used the Nifty cup for 3 feeds. So everybody got both cups to feed with. The order in which they received the cup was randomized, and then they crossed over to the other type of cup. And the nice thing about that is that then you have a group of people who had both interventions. And so you can do some really sort of fancy statistical analysis on that. If the crossover studies are not that common, I don't think they're right in the right time, but there's these things called carryover effects. And so like if you give somebody one drug, you can't just give them the second drug a day later, because that drug could still be having an effect. And so then if you give them a different drug and you cross with them over, the second drug could then be interfering with the first drug, and you don't know what's what. So they're not really that common, and they're kind of tricky, but that's an example of one. Any other questions that people have? I think I answered most of the questions. Bias and confounding, there's one question here. Oh, we're 7:20. I will leave. I think it's time to let you all get back to your busy schedules. Bias confounding, absolutely. This is the thing we worry about the most in observational studies is bias and confounding. And we want to be really careful in terms of how we think about those things in our observational studies. So I'll finish with that. Just quick housekeeping. The next module is on ethics. It's a great module. There's a really lovely case study that we'll be discussing next week. So please make time for that case study. It's incredibly thoughtful, and I think it'll be a wonderful time. Katie Porter is a lawyer who's based at Seattle Children's, who sits on the internal or the ethics review board and has a lot of experience thinking about ethics and clinical research. And so she'll be joining us to lead the session. And then if you have any additional questions that came up as part of this, I'll be monitoring the chat through Friday. I do monitor it after that, but I'm really focused on monitoring questions about this. So with that, I usually stay on, and Sarah, if you have time to stay on until 7:30 to answer any questions, housekeeping things, or follow-up questions, I'm more than happy to be here until that time. So with that, thank you for engaging. Thank you for your responses in the chat. It was really nice to see all of you, and look forward to seeing you next week.
Thank you, everybody.
Thanks, you guys.
Thanks, Sarah. Thanks, Christy.
Bye.
Thank you.
Bye.
Bye, Mubarak.
Christy, you and I wrote a paper on bias in cohort studies,
We did.
retrospective cohort studies.
We can post that paper.
We could.
Post it in the chat. Actually, send it to Joyce. Joyce.
Okay, I can do that.
And in the announcements for next week,
I'll pull it up.
there's this paper on bias in cohort studies if people are interested. Oh, cool. Yeah. Johnson, do you have questions? I love your questions. Bring them on. Fabi, Christopher, happy to take your questions too. Oh, you're muted. You're muted.
Thank you, Ma.
Hi.
You actually addressed most of the questions I have,
Good.
especially that of case series. And I read it was stated that it's less than 10. Another article says that it could be many. So it was bringing a form of confusion, but you've cleared it up now that it can be much more than 10.
Yeah.
It's still
Okay.
a form of case series. Actually like now, and then I can only say thank you to Madam Sarah. And that was a really tricky article on DO. And we don't do much of the DO in our side here, but we know it as an option to elongate the maxillary bone. So I've not had much experience in active DO, but theoretically we know that it can help expose, but rather we do most of the Leforts and the other traditional maxillary advancement. So it was really an eye-opener. I hope I'll have opportunity to see more of DO and see the effect. But we literature-wise also, we know that it does better with the elongation of the maxilla than the traditional maxillary one. But it's just that technicality involved. We don't have the DO distractors and the machine in our center. So we don't do that. We do petty alveolar bone grafts, and we look for some other ways to expand or use orthodontic appliances to expand the maxilla or what other option. But I will be looking forward to another opportunity where I will see the DO on subsequent visit. Aside that, I think it's been an interesting lecture for me. I'm learning great. Thank you, Ma, for simplifying everything. Looking
Sure.
forward to the next modules tomorrow.
Yeah.
Thank you,
I
ma'am.
will say,
And-
Johnson,
and
that the results were distraction did not lower risk of VPI. in my study.
Okay,
Sarah?
they have lower risk.
It did not.
It did not lower risk.
They do not lower the risk. Wow. Okay.
Yeah.
So the traditional maxillary advancements are better.
Well, at least in that group,
Okay.
I think, yeah. I think what I discovered, so now there are 3 studies I'm aware of that have specifically addressed this question. One of them was an RCT that limited only to like a moderate amount of advancement, and they found no difference between the 2 groups. Another study is a cohort, I think it's also a retrospective cohort study, and they found that distraction was better and resulted in less VPI. And then my study found that there was more VPI after distraction. And so the question is still not answered. And I think that what I found in my study when I went back and looked at who was actually included in my study, there were a lot of patients who had had a lot of different surgeries elsewhere and had like earlier complications, and so had multiple attempts at surgeries prior, like for palate repair. There were many more of those kinds of patients in the distraction group than there were in the conventional group. And so my hypothesis was that those patients are at higher risk for VPI, and that was why I saw more VPI in the distraction group. But stay tuned, I'm still assessing this question.
Hey, Sarah, I think when we first did this, your manuscript hadn't been published. It's published now, right?
Oh, yeah.
Can you
Yeah.
send it to Joyce? And then
Yeah.
Joyce, can you just post in the announcements with the release of module 3 that here's module 4. Here's module 4. And if you're interested in learning like what was learned in Sarah's study, here's the article. If you want to learn more about bias in cohort studies, here's another article that Sarah and Christy and colleagues put together.
Okay, yeah.
Yeah.
I can
And there's
absolutely do that
actually
today.
there's another paper under review. So if it gets published, I can send it, but that actually takes that cohort that was more at risk for VPI and compared them to those who didn't have that particular surgical history. And so that is out there too. Well, hopefully it will be soon. I don't know yet, but it's under review. I've written it. Yeah. So it's interesting because we've been talking about my dissertation for a few years now, but you can also see like the iteration of research. And so like based on what I found in one, I kind of altered my question a little bit. Maybe it's not the type of surgery. Maybe there's patient level factors that are actually important. And so, yeah, so we don't know the answer to that question yet for distraction versus a conventional. And I think from a relapse perspective, I think surgeons prefer distraction if they have to move really far because there's less risk of relapse. And so then is the patient more concerned about the aesthetic outcome or risk of VPI? And do you make surgical changes based on the patient's concerns? So there's a lot of questions to balance for that particular surgery. So
I know we're close to 7:30. Fabi, Christopher, did you have questions? Maybe they forgot to turn off their camera to say goodbye.
oh, maybe.
All right.
Okay.
Okay, excellent. All right, you guys. Thanks again, Sarah. Really appreciate the time.
And thank
Luck
you
with-
especially
you.
to Sister to Miss Joyce Doll. Thank you. You're doing
You're
a good
very
job. You
welcome,
make
Johnson.
technical
Have a
part
good
easy for
day.
me. I'm grateful. And I've been coming across your name everywhere, anywhere on Cleft. Pleasure seeing you in person, sir. Ma. Thank you,
Good
ma'am.
seeing
And
you
Christy,
Thank
too.
you. Take
looking
care.
forward to a joining discussion tomorrow. Bye, ma.
Bye, you.
Bye.
Joyce.
I need to talk to you for just a quick second.
Yeah.
All right. Christy, I'll see you in a bit.
Okay, bye, Sarah.
And Joyce, I guess. Bye.
Tomorrow, yep.
Oh, tomorrow, okay. Bye.
Bye-bye. I had a quick question about tomorrow. Zach and Laura asked me to come down early to meet with me.
Oh, okay. Does that
Do
work or no?
They said to talk about what's happening. Do you know anything about that?
No, but I said that if they needed you to do something, you could help out. I think that what I heard is something like they want to have you help bring up lunch, like
Oh, okay.
bring it up.
Okay.
I'm not sure it's really anything. It's probably just easier to tell you. So if you arrive 10 minutes early, it's fine. It's
Yeah,
not,
yeah, okay. I just didn't know what it was gonna be.
I think it's just like, because they're doing the recordings and the timing and the,
Yeah,
the
yeah, yeah.
job basically. And so I said, if you need extra help, just pull Joyce in and I'm sure.
Okay, so I just have, yeah, no problem. Okay,
Does that
I will
work?
be there about
Yeah.
8:30 tomorrow.
All right. Is that what they
Yeah.
asked?
Huh?
Yeah, because people probably, that's fine. Yeah.
Okay. The other thing to let you know, Irene's banking stuff's all set. We still don't know when she's gonna get paid, but I saw her bank account and she only has like $144 in her bank account.
Okay.
And so I'm hoping that we can get a check. But we just got on a call last night, and completed everything last night. So, and then I'll continue to work on the calendar, or at least know for the future what we need to do. But
Um, yeah, I don't, and, let me see, can you set her up with a Venmo? Can you help her
yeah,
with,
she can Venmo through her Wells Fargo account.
can she send me her Venmo information?
Yeah, I can have her do that.
Um, I will have
I
to,
almost was because the roommates wanna go do something this weekend. And I was like, do you need money? And she's like, no. And she's being really nice about it, but we're a little worried about it too.
yeah, have her send me, her Venmo.
Okay.
and I'll send her $500
Okay.
and she can just Venmo me
Thank-
back. But I
Yep.
make sure she has her Venmo and just tell her I'm gonna send her some money. And then
Okay.
she me back as soon as she gets paid.
Yeah.
That's fine.
Yep. Okay. I think that's everything, Christy. So
Joyce, I can't thank you enough.
no,
Rock.
no, it's no problem. I feel like lately I've been discombobulated, so sorry about that, but yeah.
Have not. You've been wheeling and dealing. Realities of what is this work, which is kind of messy and
Yeah, yeah.
thank you so much. I am
No
so,
problem.
and I'm glad you're gonna be at Bloom tomorrow.
Yeah, I'm gonna be, yep. And Zach got, was like, this is how you get to the building. So I'm not stressed about that because I was so stressed about having to like park and walk and because I just can't walk that far. And I was like, oh God. Then so
This, or
what? Yeah, so there's like a button that you ring into and you talk to the front desk and they'll let you in and then you have to pay for it.
practice is like a 10-minute walk. That's dinner. Are you coming to
Oh,
dinner?
I'm gonna miss dinner.
Okay. All right.
Yeah.
Zach,
Yeah, have a PTO thing tomorrow night. So,
okay.
but I should be at cricket club.
Oh, great.
Yeah.
That's more
It's just
important to me.
yeah, you said that. So I'm making sure that I'm doing all
That's
that.
great. That's lovely. Okay.
Yeah. Because I would like to meet Irene and I
mhm.
would like to, meet Isabel and Edie too. So
Yeah, and they're gonna be next Wednesday, because I have some clothes for Irene, and I thought she was gonna be at a meeting yesterday, but she had class.
yeah.
So, yeah. Okay. Well,
Okay.
I will see you tomorrow,
I will be there.
and
I will be there.
And you can go ahead and release module 3
Module 4.
or
Okay. Module 4, and then when I get those articles, I'll release everything. It takes a minute to get it to YouTube, but it's been a lot quicker than it was last year, so that's nice.
good. Yeah, and
So
you might need to. If you don't hear from Sarah, just post the module and then
yeah,
follow up with her like in 2 days because she has a grant due tomorrow.
I
So
know. I
so
felt bad
just
for her.
you can post it and then follow up with another announcement. Say, do you want to learn how Sarah's study turned out? Do you want to learn more about bias and confounding studies? You know, here are some
Yeah.
articles Sarah put
They had
you know.
good questions this time.
Uh-huh.
I think it really works well when there's 2 of you too. Like to, you know,
Yeah.
maybe
Yeah.
if I start to learn this stuff that great, so I can be like, so.
I think it's people are intimidated to ask questions, you know, so the chat worked great too, right? Lots of
Yeah.
people adding in there, which is
And
great.
you were right on top of that, so I was like, okay. I
I was like,
just was
I'm like, I don't remember. I'm like, oh, you know, it also helps me because I can keep pace of the class
yeah.
and, you know, and kind of keep it going. So we can get to the other questions that people had.
It was good. And we had 24, so 21, and they all stayed in, and so it's been pretty average. It's nice.
Good. Yeah.
Yeah.
All right.
They're not turning in their assignments as much, but
I thought I'm like 9. I'm like, huh. Then we
yeah.
started class, there were too many people there. And then actually, like if you see, I started muting, I'm like, who is that? Right? Like the phone going off or whatever.
I
It's
give
just
it one time, and then the second time I go and mute, you know, but I normally I'm right on top of it, but I was worried that it was because it was a translating thing, that if I muted him, it was going to turn it off, but yeah, it didn't, so it was good.
yeah. Okay.
Yeah.
All right.
Okay. Okay. I gotta figure out what to get for lunch for Emily on Friday. Struggling.
Just
Yeah.
all right.
Bye.